We're going to talk about spinal cord injuries. This can be found in your Lewis textbook. So it's a sudden impingement on the spinal cord, and about 55% of injuries are linked to traumatic causes, most notably motor vehicle accidents and falls in the elderly population. It can lead to a fracture that actually can cut, compress, or sever this cord. Our manifestations are going to depend on the location and the extent of damage. The alterations can be temporary or permanent, and we're typically going to see sensation and mobility problems below the level of the lesion or injury, and we're going to see a damage to the nerves that connect our central nervous system to our organs and peripheral tissues. Patients who have spinal cord injuries are living longer with a higher quality of life, so we see a decrease in mortality with them. And it really has to just do with modern technology and advancements we've seen with spinal cord injuries. Despite the physical limitations with patients with spinal cord injuries, we also see a lot of psychosocial and emotional problems. So disruption in growth and development, alteration in family dynamics, economic loss and loss of identity or self. So these patients, some of them have been head of household, and contributed financially to their families. At this point, some of them are not even working, and so they may be very dependent on their families for everything. About 90% of spinal cord injury patients are non-institutionalized, which means they're being taken care of at home by their families. About 45% of spinal cord injuries are also linked to non-traumatic causes, so benign tumors, spinal infections that lead to spinal abscesses and a subsequent compression of the cord, are temporary neuromuscular conditions like Guillain-Barré. All have the potential to lead to spinal cord injuries. This picture is a T9, T10 epidural abscess that led to a complete injury, so it was leading to an actual compression of the spinal cord. So we can classify our spinal cord injuries based on mechanism of injury. How did it happen? The level of injury and the degree of injury. So back to the mechanism of injury, was it a flexion? Was it a hyperextension? Or was it a compression injury? The level of injury, cervical, thoracic, lumbar, or sacral. More of our injuries we see in spinal cord patients happen in the cervical and lumbar regions. Is it a complete or incomplete injury? So about 60% of all spinal cord injuries are incomplete, which is a change in the numbers over the years, and that just has to do with our knowledge of how to stabilize these patients a little quicker, a little bit more efficiently, so we can actually reduce the incidence of turning a complete injury into a complete injury. Just another picture of a mechanism of the cervical injury. So it looks like a hyperextension and a hyperflexion injury. So another picture that shows the different types of injuries. Picture A is a flexion injury, which leads to a sudden excessive force, which has led to the rupture of the posterior ligaments. Picture B shows an injury from an acceleration-deceleration force, which has led to the rupture of the anterior ligaments. Picture C is a compression fracture from a diving accident, which led to the force of bony fragments into the spinal canal. And then picture D is actually a flexion rotation injury, which leads to the tearing of the ligaments that support the spine. And this is actually one of the most detrimental of the injuries that can actually lead to a complete transection of the cord. Another picture of an L1 burst fracture, which has led to a compression with an incomplete injury, which led to bladder dysfunction and bowel dysfunction. So if we wanted to look at the numbers for spinal cord injuries, about 12,000 new cases of spinal cord injuries occur per year, and there are 260,000 that are living in the U.S. with spinal cord injuries. The mean age for spinal cord patients is about 40, which is a far cry from 30 years ago where it was 28. And I think that rise in number has to do with our increased life expectancy, that increased traumatic causes of the elderly population with spinal cord injuries and their falls. So I think we've just offset that number a little. If we wanted to break it down by race, about 66% of patients with spinal cord injuries are Caucasian. In high-risk populations, young men, about 80% of spinal cord injuries occur in the adolescent and young male population. People who are impulsive risk takers. There is definitely a link to alcohol use and illicit drug use with spinal cord injuries. Sports such as football, rugby, occupational exposures, roofers, they're a high-risk population for spinal cord injuries. And as we mentioned, our elderly population with falls, tripping. And like we said, there's an increased life expectancy, and there's also an increased activity level for patients who are elderly, like increased socialization, increased activity level. So we've got two types of injuries with our spinal cord injuries. We have got the primary insult and we've got the secondary insult. The primary is the injury to the spinal cord that occurs at impact. It's an initial mechanical disruption of axon nerves as a result of the stretching or laceration of the cord. So our secondary injury can actually cause more damage than the initial insult. So it's an ongoing progressive damage that occurs after the initial insult. And in the grand scheme of things, it leads to the autodigestion of the cord. So the initial insult leads to hemorrhage, vasodilation, with subsequent edema and ischemia to the cord, which causes an infarction and necrosis. And this is just a pathophysiology map that just kind of further maps out the secondary injuries. So less than 24 hours, permanent damage may occur because of the edema. And really it's because of the lack of space within the spinal cord. It's encased within the vertebrae. So there's very little room for movement. So the extent of damage can occur from both the primary and the secondary injuries. So until the secondary injury is resolved, which is about 72 hours after the initial insult, so the prognosis for these patients cannot be determined. And this is an important component to remember. So the ASIA impairment scale is just a tool to score patients with spinal cord injuries. It just gives a level of impairment to them. They need to be given an ASIA score within 72 hours of injury. And they don't get one score during their time within the hospital or within their rehabilitation. A lot of your incomplete injuries will go up and down on the scale depending on their level of recovery. And so if you can kind of look at the scale, it's a lot better to be a level D versus a level A. So the lower you go down on the score, the less impairment you have. The higher up you go, the more impairment you have. So somebody who is an ASIA A is going to have more of a complete injury versus somebody who has an ASIA D. So it just gives some guidance for rehabilitation and the possibility of recovery, and it also is used as a communication tool amongst healthcare providers. So this is just another image about the levels of injuries and kind of where they are for movement. So somebody who has an injury at the C4 above, they're going to be quadriplegic, or tetraplegic is what we now refer to it as. So they're going to be tetraplegia results in the complete paralysis below the neck. The patient who has a C6 injury is going to have paralysis of the hands and arms as well as the lower body, but they're still going to have some movement within their neck and maybe their shoulders. A patient who has a T6 injury, they're going to be known as a paraplegic, and they're going to have paralysis below the level of the chest. Somebody who has an L1 injury, they're going to be paraplegic, but they're also going to be paralyzed below the waist. So our clinical manifestations are going to relate to the level and the degree of injury. As we mentioned before, patients with incomplete spinal cord injuries are going to have variable manifestations. They're going to have a mixture because they may not have complete loss of sensation or motor function below the level of injury. So it makes sense that patients with higher level injuries and people who have complete injuries are going to have much more serious manifestations. So if we had to look at manifestations from the respiratory system, our patients who have an above C4 injury, so a C1, C2, C3, are going to have the total loss of respiratory muscle function. So at the onset of injury, these patients are going to need to be intubated or trached, and they're going to need to be put on the mechanical ventilator. They're going to have a complete loss of muscle function, and we're going to need to support them. For our patients somewhere around the level of C4, they're going to have problems with respiratory insufficiency. So they may not necessarily need to be intubated initially, but we need to watch them closely because if edema occurs around the injury site, it could progress very quickly up the cervical cord and lead to a higher level injury. So these patients need to be watched. They may not need to be intubated initially, but it's a possibility. And we also have to worry about these patients for hypoventilation and just respiratory insufficiency. So they may at some point need to be intubated because they just can't maintain effective respirations. They may not be able to cough effectively. So your patients with lower cervical injuries and higher thoracic injuries, they're going to have paralysis of the abdominal and the intercostal muscles. So they're going to have problems with coughing effectively. So even though they can breathe well, they're not going to be able to keep their airway clear. So they're going to be at risk for developing atelectasis, pneumonia. So we're going to need to watch them closely. So cardiovascular-wise, so our patients who have a T6 and above injury are going to be at risk for cardiovascular instability. And this is because there's going to be a impairment or loss of the sympathetic nervous system. There's going to be an instability with transmission of sympathetic nervous transmission along the cord. So you're going to see a lot of problems with bradycardia, so a slow heart rate. And we're talking about getting down into the 30s and 40s. We're going to see peripheral vasodilation. So we're going to see a lot of distribution of fluid loss. So they may not necessarily be dehydrated, but they will be relatively hypovolemic because of the massive vasodilation. So we're going to see a decrease in stroke volume with subsequent cardiac output. So we're going to see hypotension. Okay. So hypotension, bradycardia, big issues with patients who have T6 and above injuries, especially at the onset of injury. So these patients, we're going to make sure that they're on ECG continuous monitoring. If their heart rate starts to get down into the 40s, we're going to give them atropine, 0.5 milligrams IV push, and we can give it up to 6 times, up to a total of 3 milligrams. If we have problems with hypotension, we're going to make sure that we adequately volume resuscitate these patients. And once we get their volume to where it needs to be, we can use vasopressor drugs. Dopamine, I believe, is what's been kind of stated in the book as far as to support blood pressures with spinal cord injury patients. These patients are also having risk for DVTs and pulmonary embolism. This has a lot to do with the pooling because of the peripheral vasodilation. These patients are going to have pooling of blood, and they're not going to be able to move, and they're also not going to be able to feel. So they're not going to be able to help us identify DVTs in these patients. So we're going to have to do good objective information collecting on these patients. So urinary manifestations in the acute phase of a spinal cord injury, these patients can also be incontinent at the onset of injury, but they're also going to have a lot of problems with urinary retention. Okay, so their bladder is going to become atonic, so there's not going to be any tone. So they're going to be over distended, so at risk for urinary retention. So we need to make sure that in the acute phases, we're going to put an indwelling Foley catheter in these patients. In the post-acute phase, as these patients move into the rehabilitation phase, some may change from being bladder atonic to actually becoming hyperirritable, and they may have problems with spasms. This is an important slide to remember. Our patients who have an above the T5 injury have problems with decreased gastric motility. So things are not moving well through their GI system. So they're at big time risk for a paralytic ileus. Okay? So we need to make sure that we are adequately assessing their bowel sounds, assessing for gastric distension. In the event that somebody does develop a paralytic ileus, we're going to put in an NG tube, nasogastric tube to decompression. Okay? And we can use Reglan or metoclopramide IV push to kind of stimulate gastric motility. However, if we do develop a paralytic ileus, we may not be using Reglan if we actually have that diagnosis of the ileus. Okay? So definitely T5 and above, usually 2 to 3 days after the initial install is when it's going to happen. So we need to make sure that we're assessing for bowel sounds, gastric distension. If they have an ileus, we're going to drop in an NG tube and put it to decompression. These patients are also at risk for stress ulcers, just directly related to the stress of the injury and the increase in hydrochloric acid production. So we're going to be monitoring, if they have an NG tube, we're going to be looking for any coffee ground emesis that may indicate to us gastritis or an upper GI bleed. Because a lot of these spinal cord injuries can present with a trauma. They're considered a trauma patient, so they may have some internal bleeding, abdominal bleeding, and we may not know it because they're completely unable to tell us. So we need to be looking to see if there's an expanding abdominal girth. Do we have hypotension that's not responding to fluid resuscitation or to pressors like dopamine? Are we having a drop in our H&H and they're not responding to blood transfusions? So definitely be looking for possibilities of intra-abdominal bleeding if you've got a patient who's got a higher level injury where they can't feel anything in their abdomen. So our gastrointestinal system, so like we just mentioned, the paralytic ileus, most of these patients also with higher level injuries can be incontinent of stool on admission. So bowels are initially areflexic with decreased sphincter tone. As patients start to move through their rehabilitation phases, when their reflexes return, if there is a patient who has a T12 and above injury, a lot of times these patients may not be able to feel anything below the level of the injury, but some gastrointestinal coordination is still present. So often the sphincter tone is very enhanced within the rectum. So reflex emptying occurs, which means after these patients eat, things move down through the GI system into the rectum. Once that pressure occurs in the rectum, it will just empty spontaneously. Okay? So the problem with that is these patients will just randomly go in bed or when they're out in the community. So it's a problem. So if a patient has a lower T12 injury and lower, and when their reflexes return, these patients are typically going to have a flaccid bowel, which means they don't feel anything, but then there's also a decreased tone. So these patients are at risk more for constipation. So regardless of whether these patients have a flaccid bowel or problems with enhanced sphincter tone, they're going to be doing a bowel program to kind of keep them regular. And they're going to coordinate it with the gastrocolic reflex. And we're going to talk about that in a few more slides later. So the integumentary system, obviously these patients have the potential for skin breakdown, okay? Early, okay? These patients are going to be strapped to the backboard for a while. They can start to develop skin breakdown at that time, at the onset of their injury. And it's secondary to just reduced mobility, okay? Sometimes we're afraid to move them in the beginning for fear that we're going to cause some problems, further damage to their spinal canal. So we also are going to have some problems with heat, body temperature conservation. These patients are going to have, as we mentioned, interruption of the sympathetic nervous system transmission above the cord or along the cord, especially below the level of the injury. So they're going to have a difficult time maintaining their body temperature. So a lot of times their body temperature will start to adjust to that of the room temperature of the environment. So they're also going to have some problems, their ability to sweat or shiver below the level of the injury. So it's going to be more common with patients who have cervical injuries. So these patients, if the room is cool and we're not being cognizant of keeping them warm, their body temperature can actually mimic that of the room, and their body temperature can drop and become very cold. And subsequently, too, when it becomes very hot and we overheat them and we put too many blankets on and the room is hot, their body temperature can rise. So they're also going to have a hard time sweating or shivering to compensate for their body temperature. So we need to be cognizant of that when we're attempting to adjust their body temperature. So the cord damage, like we said, it's going to be the degree of functional recovery is going to depend on the location and the extent of the injury. Is it a complete loss or is it an incomplete loss? So there's going to be some syndromes with incomplete cord damage. We're going to talk about just a few of them. So patients who have a central cord syndrome, there's going to be the damage to the central spinal cord, and it's going to involve the central motor fiber, and it's going to most commonly occur in older patients who have had a fall with a hyperextension or flexion injury, and it's going to most commonly occur in the cervical region. The most notable thing about a central cord syndrome in somebody who has an incomplete injury is that the upper extremities are going to be affected more. So we're going to see motor weakness and sensory loss in both the upper and the lower extremities, but we're going to see more weakness and sensory loss in the upper extremities. And in somebody who has a central cord syndrome, we're also going to see a lot of burning, abnormal sensations in the hands. So in somebody who has an anterior cord syndrome, it's going to be a damage to the anterior spinal artery from a compromised blood flow. And this is typically going to result from a flexion injury, the result of vascular compromise. So in these patients who have an anterior cord syndrome, we're going to see motor paralysis, loss of pain and temperature sensation below the level of injury. We're also going to see the maintenance of light touch, pressure, position, and vibratory sensation. So in somebody who has an anterior cord syndrome, we're going to see motor paralysis, loss of pain and temperature sensation below the level of injury. And then somebody who has a Brown-Séquard syndrome. And this is usually going to be linked to somebody who has had gunshot wounds or a stabbing or a penetrating wound. It's going to be damage to only one half of the spinal cord. So we're going to see ipsilateral or lesion side loss of motor function below, ipsilateral loss of light touch, pressure position, and vibratory sensation below. Okay? So that's just on the side of injury. And then we're going to see contralateral loss of pain and temperature sensation. So opposite side of injury, loss of pain and temperature sensation. So that's Brown's accord. So spinal shock. So this is a really important slide to remember. So a lot of your patients who have higher level injuries, spinal cord injuries, can present with spinal shock. So spinal shock is not the same thing as neurogenic shock. So with spinal shock, there's going to be a loss of autonomic, sensory, reflex, and motor activity below the level of injury. So these patients are going to be completely flaccid. They're going to have a loss of deep tendon reflexes, perianal reflex, loss of any type of sensory and motor function. So it directly is linked to the cessation of impulses from the higher brain centers. It can occur almost immediately after injury, and it can last from days to months. So what happens with somebody who has spinal shock, as it starts to resolve, we might see spasticity and hyper reflexes, and some of these extremities below the level of lesions. So we know that spinal shock is resolving when we start to see some spasticity and hyperreflexes. Okay? So spinal shock below the level of the injury, we're going to see almost immediately complete flaccid paralysis, loss of reflexes, loss of sensation and motor function. As spinal shock starts to resolve, we might see spasticity and hyperreflexia. So it occurs in about 50% of patients with acute spinal cord injuries. And a lot of times when spinal cord injury occurs, it's really difficult to determine the extent of their damage until it resolves. And with spinal shock, there is no treatment for it. We just have to let it resolve. So neurogenic shock, it's typically going to happen in patients who have a T6 or higher injury, common in cervical injuries, okay? And there's going to be a complete abnormal vasomotor response to the injury. So there's going to be a disruption of sympathetic nervous system impulse from the brainstem below the level of the injury. You know, as we said, these patients are going to have problems with peripheral vasodilation, pooling of blood. Okay? They're not going to have any kind of sympathetic nervous impulse transmission below the level of injury. So we're going to see bradycardia, we're going to see hypotension, and we're also going to see problems with the inability to sweat below the level of injury. Okay? So there is a temporary loss of autonomic dysfunction. It can occur almost immediately after injury. Okay? So some key components, remember, about neurogenic shock. Patients who have T6 or higher injuries, there's going to be a complete disruption of sympathetic nervous system impulse, temporary loss of autonomic function. So we're going to see hypotension, substantial drop in blood pressure, bradycardia into the 40s, 30s. And their inability to sweat below the level of injury, which makes it difficult to control these patients' body temperature. These patients are also at risk for something called autonomic dysreflexia. Okay. This is a key component to remember as well about autonomic dysreflexia. Usually is going to happen in the rehabilitation phase. It's not going to happen in the early phase after injury. These patients who have T6 injuries and above are at an increased lifelong risk for autonomic dysreflexia. It's a massive, uncompensated cardiovascular reaction to a certain stimuli. Okay? It's going to be an exaggerated autonomic response. Okay? That's going to be mediated by the sympathetic nervous system. Okay? It's going to be an increase in sympathetic nervous system outflow that's not going to be uncompensated by the parasympathetic nervous system. So the parasympathetic nervous system is not going to be able to counteract the sympathetic nervous system below the level of injury. Okay, so as a result, the most common thing that you think of with autonomic dysreflexia is severe hypertension, way above 200, 220s, 230s, with subsequent reflex bradycardia. Okay, so those are the big two components that you think of with autonomic dysreflexia: severe hypertension and bradycardia. This is going to happen in the rehabilitation phase. It's not going to happen in the acute phase. Okay? So some other symptoms that we might see along with the autonomic dysreflexia with the hypertension and bradycardia is massive headache, flushing, and diaphoresis. When autonomic dysreflexia happens, it's very quick in onset. Okay? It's very important when patients who have a T6 or injury or above and they're complaining of headache, palpitations, they're flushed, they're diaphoretic, it's really important for us to check their blood pressure. Okay? So what happens is there's a specific stimuli, and we're going to talk about those precipitating causes on the next slides, that stimulates the sympathetic nervous system response, okay, which is going to lead to vasoconstriction above or below the level of the injury, okay, and we're going to see an increase in blood pressure. Okay, and normally that increase in blood pressure is going to stimulate parasympathetic response to counteract that sympathetic outflow. Okay, the problem is the parasympathetic outflow can't get below the level of the injury. Okay, so it can affect the SA node, and that's why we're going to see bradycardia, because the parasympathetic outflow can reach the SA node, so we're going to see a drop in heart rate, but it can't get below the level of injury. Okay, so that's why it can affect above the level of injury the parasympathetic nervous system. So that's why we're going to see vasodilation above the level of injury. So that's why we're going to see flushing, diaphoresis up above, and we're going to see headache from the increased blood flow up above. But below the level of injury, we're not going to see parasympathetic compensation. So we're going to see lower below the level of injury. We're going to see paleness, coolness. Okay. So a lot of the precipitating causes of autonomic dysreflexia is going to be bladder distension. Okay. If a patient has a lot of urinary retention, okay, that's a big component. So if a patient has autonomic dysreflexia, we want to make sure that we're checking for bladder distension, urinary retention. Patients can have urinary tract infections, stones. If a patient is constipated or impacted, that could lead to autonomic dysreflexia. Somebody who has a pressure ulcer, maybe they have constrictive clothing, maybe they're lying on a cord or a hard surface. A lot of patients, when you catheterize them or when you check for an impaction, actually might induce autonomic dysreflexia. So these are all of the causes that can induce AD. Okay. Just another slide that talks about rectal stimulation that can cause autonomic dysreflexia. So a lot of our diagnostic tests for spinal cord injuries, obviously x-rays that can kind of rule out fractures, because a lot of these patients present with trauma. The problem with spinal x-rays for spinal cord injuries is that about 57% of injuries are missed with an x-ray. So your CT scan is your gold standard for spinal cord injuries. If you're at a place that doesn't have a CAT scanner, you can do a spinal x-ray. It's better to do a lateral to see the cervical region in that area. But like we said, spinal x-rays can identify other injuries over the spinal cord. But like we said, the CT scan is the gold standard. So you are a little concerned with the frequent CAT scans with some of the exposure to radiation. You can do an MRI at some point after the patient's stabilized if you want to look at the more specifics of the fracture. You want to look at the site of compression if the cord is being compressed by the vertebrae. You want to look at some of the soft tissue damage and some of the edema. And obviously on admission, you want to look at their history and physical. You want to determine the level of injury and the extent of damage. You're going to do, remember we said an ASIA impairment score within 72 hours. And we're going to be doing labs. We're going to be looking at their H&H because they are a trauma patient. We're going to be looking at their white count. We're going to be looking at their coags. So collaborative care, emergency management. Obviously, these patients are going to be mostly trauma patients, so patent airway. And the first thing that we're going to be doing is stabilizing their cervical spine. So we're going to be putting on the cervical collar, putting them on a backboard, and putting the blocks on either side of their head. We're going to make sure that we've got them oxygenated. We're going to be establishing IV access in the antecubital, large bore, assessing for other injuries. Like we said, we're concerned about abdominal injuries in patients who have higher level injuries where they can't feel. We want to make sure that we're controlling any type of external bleeding, obtaining the appropriate imaging, CT scan, x-rays when appropriate. And we want to anticipate preparation for stabilization with surgery or with skeletal traction. So once in the ER, we want to ongoing monitor vital signs. We want to be looking at their heart rate, their blood pressure, their level of consciousness, because remember, if this is a cervical injury, they may have hit their head, so it can also be a head injury. We're looking at their SATs. We're making sure if this is a cervical injury, if these patients are having an escalation in their level of injury, are we having to think about intubating them? Looking at their rhythm, looking at their urine output, keeping these patients warm. We're making sure that we're watching their temp, making sure that we're not keeping the room too hot, not making sure we're keeping it too cold. We're going to put a Foley in because we're worried about urinary retention. And we're going to also look for their gag reflex. Like we said, once they're stabilized, we're going to obtain the history of the incident. We want to know exactly how the injury happened. And like we said, we're going to do an ASIA impairment score. So we're going to look at their muscle groups. We're going to do a sensory exam. And we're going to do a neuro check. And when we move these patients, which is completely important, it's very important for you to remember, we're going to roll them as a unit. So we're going to log roll them. We want to make sure that we keep their spine aligned. So when we want to stabilize and decompress their spinal segment. We want to think about traction or realignment. We want to eliminate damaging motion, and we want to prevent any secondary injuries or damage. So this is an important component to remember. So surgery for stabilization is only indicated if there is evidence of cord compression, or if we think, or if they are able to visualize on CAT scan that there are bony fragments, or if there is a penetrating wound. Okay, so the only time that we're going to be doing surgery for stabilization is if there's evidence of cord compression, if there's fractures, bony fragments, or penetrating wounds. Here's just a picture of a post-accident C5 spinal cord compression fracture and surgical stabilization. All right, so collaborative care for drug therapy. So as we said, vasopressin agents, we want to make sure that we keep the spinal cord perfused. Like we said, remember, we want to prevent any secondary injuries. So we want to keep the mean arterial pressure greater than 90. And so we might consider using vasopressor agents after we've utilized fluid volume resuscitation. Okay, so dopamine. Because these patients are at risk for VTE, remember there's going to be pooling in their lower extremities. There's also going to be decreased movement. They're not going to have sensation. We're going to use low molecular weight heparin unless it's contraindicated, unless we speculate that there's a bleed. Okay, so we need to use VTE prophylaxis. For a while, steroids were used in the acute setting for spinal cord injuries. They thought that it helped prevent some of that secondary injuries. But methylprednisolone is no longer indicated for spinal cord injuries. They almost feel like that it's more detrimental using methylprednisolone for its increased risk for GI problems, long-term implications, osteoporosis. So obviously a lot of our nursing diagnoses, impaired spontaneous ventilation with our C1, C2, C3 diagnoses. Any of our respiratory nursing diagnoses like altered breathing pattern, ineffective airway clearance. And then any of our patients who are having problems with cardiac instability, decreased cardiac output, risk for autonomic dysreflexia. And then we're going to have a lot of problems with urinary elimination, bowel elimination, risk for impaired skin integrity. So from a health promotion standpoint, our role is to identify patients at risk. We said adolescents, risk takers, elderly people at risk for falls. So we need to make sure that we are supporting legislation that promotes prevention activities, seatbelt laws, tougher restrictions on drunk drivers. And we also need to be focusing on some of our nursing interventions, a lot of teaching and counseling that we're doing for some of these patients with spinal cord injuries. It's important to emphasize that health promotion, health screening, in addition to spinal cord injuries. So after injury, health promoting behaviors can have a significant impact on the health and well-being of patients with spinal cord injuries. Patients don't die from spinal cord injuries, they die from secondary complications. So it's important that we're talking about smoking cessation, reduction of alcohol use, because a lot of these patients, that's what they may use, smoking, alcohol use, illicit drug use, to reduce a lot of their anxiety and depression. And so we need to be doing a lot of teaching and counseling, education. And we also need to be referring them to recreation and exercise programs and support groups out in the community. So let's talk about some acute interventions. As we mentioned, immobilization is extremely important, okay? We need to make sure that these patients are staying in a neutral position. We need to stabilize them to prevent any kind of lateral rotation. So putting them on a backboard, the hard cervical collar, and we need to make sure that we put the blocks alongside of their heads, or we can use rolled up towels. We need to make sure that they keep their body correctly aligned, and if we have to move them, we need to log roll them. So skeletal traction, if surgery is not indicated, but a lot of times you're not seeing a whole lot of skeletal traction anymore because they're doing a lot more surgery to stabilize and realign. So it's meant to realign or reduce the level of injury, and we're going to use ropes, pulleys, and weights. The traction is continuous. It needs to be maintained at all times. Our role, this picture that you're looking at is a Gardner-Wells tongs. They're used to provide traction. So it's going to be provided by a rope that is extended from the center of the tongs over a pulley and has weights attached at the ends. So the traction must be maintained at all times, which is extremely important. But the big problems with some of these skeletal tractions like the Gardner-Wells tongs is that they can actually start to pull out from the skull pins. And we also worry about infection. And we also worry about immobility with these patients. So the tongs and tractions typically are going to be removed 1 to 4 weeks after injury. So if the skull pins actually start to come out of place, it's going to be our job to keep this patient's head in neutral position, have somebody call the physician and stay with the patient until the physician gets there so they can actually put back in the skull pins. So infection, like we said, at the insertion site is a big issue, so we need to make sure that we're providing aseptic technique when we're cleaning the pin sites on the side of the head. We need to make sure that we're using normal saline solution, sterile, twice daily, and if it's asked, we're going to be using antibiotic ointment around the sites. All right, so these are just another example of the Gardner well tongs. Like we said, they're not being used a whole lot because if we need to do alignment and reduction and to remove some of the compressed fragments from the cord, we're going to be going in and doing surgery. All right, so after cervical fusion or stabilization surgery, we might be using a SOMI brace. We can also use more of a halo fixation apparatus, and they can stabilize the cervical spine. We can also, with the halo vest, if it hasn't been used after surgery, we can actually put some weights and we can actually put tongs that can be incorporated into the vest to stabilize the injury area and allow ambulation. So our role with these patients who've got SOMI braces and halo vest, we need to make sure that we're doing meticulous skin care, okay, because it's important because they have decreased sensation and circulation and they're susceptible to skin breakdown. So meticulous skin care, skin evaluation with these patients who've got SOMI braces on after cervical stabilization, and a halo vest if these patients have not had surgery. All right, so we talked about respiratory dysfunction in our patients who have got cervical spinal cord injuries or even a higher thoracic. So edema can increase the level of dysfunction. Like we said, it could start out as a C4, C5 injury, and it can progress. So we need to make sure that we're closely watching these patients for the first 48 to 72 hours after injury. We're monitoring their respiratory function. We need to evaluate to see if they need to be intubated. And because if they're a cervical injury, we can't put them in that sniffing position when we intubate. So we may have to do other methods of intubation. We may have to use video-assisted intubation with a camera. We might have to consider tracheing these patients with a tracheostomy. And as we said, we're going to be evaluating and monitoring these patients for pneumonia, atelectasis. So we're going to be listening to their lung sounds, checking their oxygen sats, listening to the force of their cough, the rate and depth of their breathing. Like we said, their O2 sats. We're monitoring for muscle fatigue, if they need to be suctioned. If they can't cough effectively, do we need to help suction them? Do we need to NP, NT suction them? We're going to be looking at their ABGs. If they happen to have an end-tidal CO2 detector through their nasal cannula, are we able to monitor continuously their carbon dioxide levels? Can they use an incentive spirometer? Do we need to get respiratory therapy involved to be doing some chest physiotherapy as they start to recover? Is that appropriate? And if they're having a lot of pain, do we need to be using pain medications judiciously before we're doing a lot of respiratory interventions with them to make it more effective? We're going to also be monitoring pulmonary function tests to be looking at their vital capacity and their tidal volumes that they're able to take in. That's an indication to us if their ability to cough and to take in enough volume is starting to decline. And as we said, we're always monitoring for decompensation. We talked about cardiovascular instability, their risk for bradycardia and cardiac arrest. A lot of these patients, if they have heart rates in the 40s, blood pressures down in the 90s, we suction them, we turn them, we do something that's going to cause them to vagal. It can actually induce a cardiac arrest. So we need to be watching them very closely. As we mentioned, increased risk for venous thromboembolisms. So as we mentioned, atropine for bradycardia, volume dopamine for low blood pressure. If the atropine doesn't work, and as we said, we can only give it several times, we may need to consider a temporary pacemaker. Okay? We need to make sure, as long as it's not contraindicated, prophylactic heparin or Lovenox, putting compression devices or boots on these patients, and doing passive range of motion. We talked about autonomic dysreflexia. Okay? These patients have some sort of stimuli that induces a sympathetic nervous response, which causes an increased blood pressure. Parasympathetic attempts to compensate and attempts to bring the blood pressure down, but it can't. Instead, it just brings down the heart rate. So our job with somebody who has autonomic dysreflexia, our biggest concern is their risk for injury. If their blood pressure is that high, it's up in the 220s, 230s, they're at risk for an MI, they're at risk for stroke, bleed. We need to find out why this is happening. What's the reason that their blood pressure has gone up? What's the noxious stimuli? Do they have urinary retention? Are they impacted? Are they in pain, but they just don't really know it because they're paralyzed? We need to monitor for signs and symptoms. We said severe hypertension, bradycardia in most patients. Below the level of the injury, we're going to see significant vasoconstriction. So we're going to see pallor. We're going to see cold extremities. Above the level of injury, because we do have parasympathetic response above the level of injury, we're going to see vasodilation. So we're going to see flushing, diaphoresis, and we're going to see headache. But below the level of injury, we've got such significant vasoconstriction with that hypertension. So we need to make sure that we take care of the offending cause. If our bladder is distended, we're going to put a Foley in. Okay? If the patient is constipated and impacted, we're going to see if we can get things moving, manually disimpact. The first thing that we are going to do, though, is we're going to get these patients their head of the bed in the upright position. We're not going to keep them lying flat, okay? Because keeping a patient flat can actually raise their blood pressure. So we want to attempt to decrease venous return, reduce their blood pressure, so we're going to put their head up. We need to make sure that we stay with the patient, and we're going to notify the physician. Okay? If we're not able to remove the offending cause and bring down this patient's blood pressure, we're going to use IV antihypertensives. We can use calcium channel blockers. We can use beta blockers. If you're in the ICU, you can use labetalol IV. And then we're also going to educate our patient and their caregivers about autonomic dysreflexia and the causes and a lot of the manifestations they need to be looking for. All right, so fluid and nutritional balance. We talked about in the initial phases, if they've got a T5 and above injury, at risk for ileus, and they're going to need an NG tube. So we're going to be looking at their fluid and electrolyte balance. If these patients have an NG tube in the early stages, they're at risk for fluid and electrolyte imbalances, metabolic alkalosis, dehydration. Okay? As we start to introduce foods, we want to first make sure that these patients have bowel sounds and they're passing flatus. Okay? The kinds of foods that we're going to introduce is going to be high protein, high calorie, okay? Because we want to utilize enough calories for energy and tissue repair. If these patients have higher level spinal cord injuries, we want to make sure that they have a positive gag reflex, that they can effectively swallow. So we might be consulting a lot with speech therapy and dietary consults. So a lot of these patients, because there's some emotional, psychosocial problems beyond just the physical, these patients may not want to eat. Okay, so we need to make sure that we evaluate why they're not eating. Okay, we want to investigate with the patient. We want to make sure that we set these patients up in a pleasant environment. We might want to consider doing a calorie count, so being pretty stringent on counting how much they eat. eating. We want to make sure patients, families bringing in foods that they want to eat. We might consider doing some dietary supplements. And then also because they're at risk for constipation, we want to consider adding some dietary fibers to their foods. As we mentioned, bladder management. In the acute phase, we're going to put a Foley catheter on these patients, and they're at risk for UTIs. So we want to make sure that we are strictly aseptic technique on insertion. We want to make sure that we're caring for this catheter aseptically, okay? Making sure that they've got adequate fluid intake to flush the catheter, to decrease stasis. And in the long-term phase, as these patients move towards rehabilitation, depending on what the return of their bladder function is, we might consider doing an intermittent catheterization program if they're able, if their level of injury is low enough that they can actually straight cath themselves every 3 to 4 hours. Okay? We want to talk to these patients and their families, and also for us, we want to monitor for signs and symptoms of UTIs. So since the induction of doing indwelling catheters in the acute phase for spinal cord injuries, the mortality rate has actually decreased substantially in these patients over the years. So some of the things that we want to do for our patients who have bladder dysfunction, as we said, establish bladder dysfunction. What's the type of bladder problem they have? Do they have problems with reflexia? Are they hyperirritable? Do they have no bladder tone? Or do they have a mixture? We want to encourage activity when we're able, when it's appropriate for the patient, individualized to their level of injury. Okay? We also want to make sure that if it's appropriate, encourage sufficient fluid intake, at least 3 to 4 liters a day. A lot of these patients who are immobile, they can have bone demineralization, which means they can have an increased bone resorption, so they can have elevations in calcium levels in their serums. So in some of these patients, we might consider restricting fluids in the evening. Normal positioning when they're urinating if they're not somebody that's going to have a catheter, or if they're not going to be intermittently catheterizing themselves. And we're going to establish a voiding schedule. So some of these patients who have a hard time controlling their body temperatures, so they have a hard time with vasoconstriction, piloerection, or heat loss through perspiration below the level of injury. So we need to make sure the temperature controls the external. Okay? So monitor the environment and their body temperature. So we want to make sure that when we're bathing these patients, that we want to make sure that we keep the room comfortable and we keep them covered. Okay? We don't want to unduly expose them. We also don't want to overload them. So when they have infections and they have high temperatures, we want to make sure we're doing everything that we can to make them comfortable and so that they don't overheat. Stress ulcers, like we said, they're at increased risk because of the physiological stress of the injury, and especially if they're mechanically ventilated. We want to make sure that we're monitoring their stools, their gastric contents, and looking at their hemoglobin and their hematocrit. So what we're going to do, we're going to start them on GI prophylaxis from the beginning. We're going to either start them on Pepcid or Prilosec. Okay. So sensory deprivation, okay, so secondary to absent sensations. So we want to make sure that we continue to stimulate the patient above the level of injury or below the level of injury. So even if they may not be able to feel what we're doing, we still want to make sure that we are touching them and letting them know where we are touching them. We want to make sure that we're still engaging these people in conversations, stimulating their other senses with music, strong aromas, interesting flavors in their foods. We want to make sure that we prevent these patients from withdrawing socially. And we want to provide them an opportunity to touch, grasp, and manipulate objects, as we said, to stimulate some of their other senses. So in the rehabilitation phase, it's complex, right? So at this point, our goal is to get these patients to function at their highest level of wellness. We want them to be as independent as possible for their level of injury. Okay, so the goal in rehabilitation is retraining their focus to manage life changes. It's a multidisciplinary team, right, of nurses, physicians, PT, OT, and many more. So it's going to be organized around the patient's individualized goals and needs. And the patient is going to be expected to be involved in therapy and to learn self-care. That is the goal. So it can be stressful, and the patient is going to need frequent encouragement. So the nurse during this time, not only is their goal is to coordinate services, but it's going to be able to motivate and encourage the patient. So there's going to be a lot of multiple complications in the rehabilitation phase. As we said, bladder bowel dysfunction, and this is going to affect the patient's quality of life. Remember, we said once spinal shock wears off, these patients can start to have a lot of spasticity, hyperreflexia, so they can have pain at this time. A lot of depression because it's not comfortable. And so sometimes with spasticity and hyperreflexia, it may give patients false hope where they're thinking, hey, maybe I'm going to have some level of movement, where it's truly not. Autonomic dysreflexia, like we talked about, the risk for VTE, pressure ulcers in the acute phase and also the rehabilitation phase. Like we said, most patients with spinal cord injuries don't die from spinal cord injury. They die from secondary complications, contractures. So neurogenic bladder. So like we said, when that atonic phase wears off in the acute area, these patients can either be flaccid, they can be spastic, or they can be a mixture with their bladder. So a lot of their common problems, they're going to have urgency, frequency, they can have incontinence, or they can retain and not be able to void. So a lot of the things that we can do for these patients, if they have problems with spasms, hyperreflexia, we can use medications like antispasmodics. We can use ditropan. Depending on the degree of their injury and also their capabilities, we can do several methods. We can do bladder training. So we can get these patients to where they're trying to void every 2 hours to get them on some sort of regimen. If they're capable, they can do intermittent catheterizations to themselves every 3 to 4 hours at home, clean technique. In rare circumstances, they might need to do an indwelling catheter. It's usually not a good idea to do a indwelling fully long term because of the risks of UTIs, fistulas. So these patients may actually need a suprapubic catheter. Some patient teaching. We're going to teach our patients how to obtain their supplies, how to use their supplies, manage different techniques with maybe keeping their catheters clean, intermittently catheterizing themselves, assessing their technique, are they doing it correctly? And then also teaching them how to identify signs and symptoms of UTIs or problems and when to seek healthcare advice. So neurogenic bowel, like we said, in the beginning, voluntary control may be lost. So usually T12 and above, when shock starts to wear off, these patients may have an increased sphincter tone, but they still may not feel anything, but they still might have some coordination within their GI system. And then T12 and below, they're completely flaccid, and even though they can't feel anything, they still are at risk for constipation because they have no tone at all. So regardless of whether it's a T12 and above or T12 and below, we need to make sure that these patients are eating high fiber diets, getting adequate fluid intake. Patients with T12 and above, they usually will do a suppository and small volume enemas every day for evacuation. And they'll also follow that up with digital stimulation for about 20 to 30 minutes after their suppository and their small volume enema. This allows their external sphincter to relax, and then they can actually induce reflex emptying. Whether these patients have a high or a low level injury, they're both going to use stool softeners every day, like docusate sodium or Colace. In very rare circumstances, should they be using oral laxatives, we want to limit use to avoid dependence. In our patients who have T12 and lower injuries, they're typically not going to use suppositories or the small volume enemas. They're actually going to have to use manual evacuation. And because some of them still have some feeling around the waist or below, they actually may be able to do the Valsalva maneuver to help push actually out some of their stool. But most of the time, they're actually going to have to manually remove their stool. And so most patients, despite the level of injury, they're going to use their gastrocolic reflex, which means they're going to do a lot of this in the morning, 20 to 30 minutes after they eat, okay, because they're going to use that gastrocolic reflex, the peristalsis, to help facilitate their bowel regime. This process should be started for these patients in the ICU. So as we said, like establishing bowel habits for patients with spinal cord injuries, establishing a bowel pattern, monitoring their frequency and consistency, scheduling evacuations after meals, like we said, 30 to 60 minutes after a meal. If these patients have lower level injuries where they can actually be sitting up, we want to make sure they're sitting in a normal defecation position, utilizing assistive measures to induce, including family members and caregivers in the bowel training program. And our overall goal for these patients is to make sure that they're going at least once a day or every other day to make sure they get on a pattern so that they're not going in their bed, they're not going out in the community so they can have a better quality of life. So as we said, neurogenic skin prevention is essential because most of these patients can die from 3rd and 4th degree skin ulcers. So we want to do a lot of patient teaching, skills to prevent, talk to patients and their caregivers about daily skin care. So for nurses who are caring for these patients, we want to make sure we're doing a comprehensive daily exam, looking at those special areas in the sacral, okay, in the trochanter area, the heels. We want to make sure we're carefully repositioning these patients every 1.5 to 2 hours, utilizing pressure relieving cushions, gel cushions, or even the low flow air mattresses. Adequate nutrition to make sure their skin becomes very resistant to the injuries. And because they can't feel and they have a hard time healing, we want to make sure that we avoid thermal injuries, heating pads, water temperature for baths. Grief and depression, these are some big key components to remember. Because we said there's an overwhelming sense of loss, their loss of control, their loss of who they were, their identity. So they're going to have some wide fluctuations in their emotions after their injuries. We need to make sure that we allow these patients to vent. And we don't want to get into any power struggles with these patients. We need to allow them to mourn while still encouraging hope, but we want to make sure that we don't give them false hope. And despite the fact that this seems kind of weird, we want to make sure that we avoid sharing other patients' success stories because not everybody is the same and everybody has a different timeline and individual recovery. Like we said, we want to encourage verbalization and accept feelings. Patients may have a lot of outbursts and it may not be personal, but we need to let them vent. We want to include clients in the decision-making process of their plan of care. So we want to encourage their participation. We want to help these patients to adjust. Acceptance is not realistic. I mean, this is going to be a lifelong process. They need to adapt and adjust to where they are. As we said, grieving, adjusting is going to be a lifelong process, and it's not going to be done in the inpatient setting. It's going to be a continuous process through inpatient rehabilitation until they go home. Okay? So we want to set some realistic short-term goals, such as, independent self-care and wheelchair use. So grief and depression, we want to make sure that we support caregiver and family counseling, because this is important so that they can support the patient. We want to encourage support groups for the patient and the family. Being sympathetic is not helpful. These patients don't want sympathy. What could help a lot is consistency of care. So making sure that they're staying with the same multidisciplinary team, definitely the same nurses, the same physical therapist. And in certain situations, it's not unheard of or unusual for patients to have mental psychiatric issues come to light. So they actually might need a psych consult. And it's, again, not unheard of for patients to be put on antidepressants or mood stabilizers. So medications may be required. So ineffective coping is going to be a big nursing diagnosis with these patients. So we need to appraise the patient's adjustment to their changes. We need to provide an atmosphere of acceptance. Like we said, provide factual information on the injury, progression, treatment. We need to assist the patient to identify positive coping strategies, not smoking, not alcohol, not anything dangerous. Encourage family support and assist the patient to grieve and work through their losses. And our overall goals is to maintain respiratory function, avoid complications of immobility. We want to make sure that we establish programs to maintain bowel and bladder function, and we want to help these patients to adjust and adapt to their lifestyles.